Hello, everyone. Welcome and thank you for joining the Interventional Psychiatry Consortium, an educational network bringing together trainees and other advanced learners for a shared educational experience in the field of interventional psychiatry. My name is Ailani. I'm one of the organizers of the consortium alongside Yaakov, Jeff Zabinski, and Gerard Ehrie, as well as our amazing advisory board. We are now over 500 members strong, representing over 70 institutions from around the world. Thank you for being a part of it. Today is the sixth talk in a phenomenal lineup of speakers covering a variety of topics, as you can see here. If you haven't already, please sign up to receive invitations to future events, and also take a brief moment to complete our survey. And speaking of what's ahead on the calendar, we're excited to share that we'll be hosting our very first in-person happy hour, the Sip and Stim series, on December 12th in New York. We'll be sending out an email soon with the details and a Google form to RSVP. Kindly do so by December 4th. We'd love for you to join us and connect with the consortium community in person. And this is just the beginning. We look forward to hosting many more events in the future. As for today, we'll soon hear from our speakers. Then we'll have a Q&A, during which time you can use the chat to ask a question or raise your hand to be unmuted. The sessions are recorded and will be made available to you all. Now, I am thrilled to introduce our speakers. Dr. Sanacora. Dr. Sanacora is a professor of psychiatry at the Yale School of Medicine and co-director of the Yale Interventional Psychiatry Service. His research integrates molecular neuroscience, neuroimaging, and clinical psychopharmacology to investigate how glutamate and GABA neurotransmitter systems contribute to mood disorders and antidepressant response. He has authored more than 180 peer-reviewed papers examining rapid-acting antidepressants, biomarkers of treatment resistance, and the neurobiological effects of stress and anhedonia. His group's work was central to translating ketamine and esketamine from experimental models to clinical practice and continues to inform the development of next-generation glutamatergic therapeutics. A recipient of the Anna Monica Foundation International Award, Dr. Sanacora continues to shape the field through scientific leadership and mentorship. Dr. Hughes. Dr. Hughes is an assistant professor of psychiatry at the Yale School of Medicine and an attending psychiatrist with the Yale Interventional Psychiatry Service. His clinical and research work spans neuromodulation and rapid-acting pharmacotherapies for mood and substance use disorders. Dr. Hughes has published on psychedelic interventions, ethno-racial inclusion in psychiatric trials, and implementation of interventional psychiatry within academic training programs. His recent work examines representation and equitable access in emerging psychiatric treatments, and he plays an active role in teaching and mentoring trainees in interventional psych at Yale. Dr. Hughes is particularly interested in bridging novel therapeutics with evidence-based clinical practice to broaden the reach of next-generation care. Dr. Sanacora and Hughes, over to you.
Great. So let me share my screen real quick. Great. Can you guys see this?
Perfectly.
Yes.
Okay, great. Fantastic. Okay. So thank you for the introduction, Simi and Yaakov, and thank you for organizing this lecture series. It's really been fantastic so far to hear from all the speakers. We're very excited to talk to you today about ketamine and esketamine. These are our disclosures. Dr. Sanacora has a lot. I have none. It's important to note that Yale does have a relationship with Janssen and might receive some financial benefits from that relationship, but we don't receive any direct benefits from that. Okay. So to get started, this is a slide that Jerry made. I think everyone from our group has presented this at some point in the past year, but it does a really good job at outlining the history of ketamine back from its synthesis in the early 60s to its first use as an anesthetic by Edward Domino at University of Michigan, to its use in the battlefield due to its limited impact on cardiorespiratory functioning, exploration of NMDA receptor antagonists in the late 80s and the 90s, and understanding its neurotoxic effects from antagonism of that receptor, and then understanding that NMDA receptors antagonists might exhibit antidepressant effects, right? So all of this led up to the first prospective RCT of IV ketamine. This was a group of 7 folks. This was done at the West Haven VA up here by several Yale faculty, including George Henninger, John Crystal, Robert Berman, and Dennis Charney. And that report showed that ketamine had the potential to rapidly and robustly attenuate depressive symptoms. 6 years later, it was replicated by Carlos Zarate at the NIMH. And over the next decade or so, there were lots and lots of trials that were created and done showing that ketamine had, again, rapid and robust effects to attenuate depressive symptoms and to suicidal ideation. So there was a lot of excitement around the ketamine treatments at this time. A lot of clinics started popping up. Jerry put out a consensus paper with some colleagues in collaboration with the APA that kind of put together the best practices at the time, that there wasn't enough data necessarily to create formal guidelines. So they came together and put their heads together and said, this is what we think an appropriate use of ketamine might be and how you might want to do that. And then in 2019, esketamine, branded as Spravato, was approved for TRD. And then in 2020, it was approved for major depression with suicidal ideation. So when we're talking about ketamine, we're talking about a racemic mixture, a 50-50 mixture of the R and the S enantiomers. These are, the same molecule, but they just have different spatial orientations. Thus, they may have different interactions with their target receptors and produce different effects. In animal models, R-ketamine does appear to have some antidepressant signal, but unfortunately, the human trials of R-ketamine were not overly positive, particularly when compared to the trials of esketamine, which have been pretty successful thus far. Ketamine touches a lot of receptors, right? I think we focus mostly on the NMDA receptor. There's a lot of attention there and its antagonistic effects there, but ketamine does touch a lot of receptors, and the sum of all these interactions ends up with ketamine having an antidepressant effect. But people are really looking into the mechanism of how ketamine works. There's an increasing interest in the mu-opioid receptor and ketamine's interactions there. But again, ketamine touches a lot of different receptors. There are other NMDA receptor antagonist drugs that don't produce the rapid and robust antidepressant effects that ketamine does. So people are looking into this actively. And if you look, if you look to the right here, this is a table showing the different bioavailabilities of the different routes of administration. And I think most people are familiar with IV ketamine or intranasal esketamine. These are the typical dosing schedules that we use, typically twice a week for some weeks. Here at our clinic, we dose IV ketamine and intranasal esketamine twice a week for 4 weeks initially. And I think that's fairly common within the field. But if you note, intravenous has 100% bioavailability. Intranasal is 30 to 50%. And importantly, I'll mention this later in the talk, that oral has about 10 to 20% bioavailability. So if you want to give someone oral ketamine, you have to give them a lot of ketamine to overcome that loss in the gut. So this is a glutamatergic synapse. And what we know about ketamine is that it will block the NMDA receptors on this GABAergic interneuron, right? Effectively releasing the glutamate transmission across the synaptic cleft and binding to these AMPA receptors here on the postsynaptic side. That will lead to an increase in BDNF binding to tyrosine kinase B and promote synaptic plasticity and the antidepressant effects that we are looking for. And this is seen in animal models. This is a paper by the late Ronald Newman, a Yale neuroscientist, showing that in control, here we see this is a medial prefrontal cortical neuron in the control side, a stress model showing some atrophy of that neuron, right? And then resumption to baseline after the administration of ketamine. We also, like I mentioned, people are looking at the mu-opioid receptor in terms of ketamine's effects there. There's been a lot of attention here. This was a paper that came out in AJP earlier this year talking about this. There's been a lot of reports about using naltrexone to block the mu-opioid receptor, which might attenuate the effects of ketamine, leading some people to conclude that, ketamine activating this receptor must be necessary. But we don't necessarily have data to say that. Something that also might be true is that we may just need a functioning endogenous opioidergic system, whereas these beta endorphins need to bind to this receptor to promote the production of BDNF rather than ketamine binding this receptor in and of itself. So anyway, this is an active piece of research. People are really looking into this, but we don't know fully yet. This is a paper from Rebecca Price up at Pittsburgh, who looked at, in the study, people got ketamine, people got placebo. The folks that got ketamine tended to have higher scores on this scale of awe, like being in awe of something. And we see that for folks that had higher scores on that rating scale, it was associated with a larger percent reduction in MADRS. And that was true. And the MADRS is a rating scale for depression. And that's true for 24 hours up to 30 days. And on the other side, we see CADS scores, and the CADS is a scale for dissociation commonly used in ketamine treatments to make sure people are back to their baseline kind of before they leave. But people that had strong dissociation didn't necessarily have a stronger reduction in MADRS. So the dissociation might not predict attenuation of depressive symptoms, but the experience of awe might. So, there may be both neurobiological bases for the mechanism of action, and also some of these experiential or subjective effects may also contribute. This is another paper headed up by Rebecca Price that was written to kind of understand the predictors or moderators of who might respond to ketamine. And this was a very large pooled analysis from several studies across the world. And they found that demographic and clinical features might not be of that much utility to predict who might respond to ketamine. There are some other reports, I think the strongest of which might be family history of alcohol use disorder. People are looking at these, looking into finding moderators, but in our clinical practice, I don't really use any clinical or demographic features to make my determination if we're going to treat someone or not. This is a report that came out earlier this month from real-world patients. I like to look at research patients, but I think reports from real-world patients are of great utility, given that research patients are often hand-picked and might not mirror the patients we'll see in our day-to-day clinical practice. So from this study, NF200, this was a retrospective study, I think the most salient piece here is they found that fewer antidepressant failures were associated with greater improvement. And this is something that we've known for a long time, even going back to the STAR-D study, where with each subsequent failure, the chance of remission and response diminishes. But I think it's an important point to hold on to, and I'll mention this again later in the talk. So this is a paper that was written by our colleague Samuel Wilkinson, and it's something that's really a concept that's really important to understand when you're talking about clinical trials with psychoactive drugs where when you take it, you may feel a subjective difference from your baseline. And in this paper, they found that when ketamine was given compared to an active placebo, such as midazolam, the difference between the groups was much less than when ketamine was given with an inactive placebo or saline. And the reason behind that is likely due to expectancy, whereby if someone gets something like midazolam and they feel, a little tingly or they feel kind of off of their baseline, they might conclude that they got the active treatment, and then they might believe that they're going to get better, and that can influence the outcomes. So it's a really big reason why, you know, these active placebo trials are probably stronger than the placebos that are inactive. And we see this also in clinical trials with psychedelics. This is a really funny comic. I think Jerry shared this with me, but it outlines that point where this group that's kind of hanging out, chilling, says, you know, so I'm guessing we're in the placebo group because this group here has their clothes off and they're dancing in a circle. So, you know, the unblinding, if present, might influence the outcomes of the trial. So oftentimes when I'm seeing folks, people ask me, you know, what should I do? Esketamine? Should I do ketamine? What works better, etc. And there's a lot of papers that have been published to try to describe just that. There's several systematic reviews and meta-analyses that look at ketamine versus esketamine. Overall, it seems that ketamine may do numerically outperform esketamine, but not in a statistically significant fashion. There are also real-world reports, including one from our clinic here by our colleague Sina Nikayan, where we found a similar result where ketamine seemed to outperform, but not in a statistically significant fashion. Overall, response and remission are such, about 50 and 30% respectively, and durability is relatively low. So again, when people ask me which one should I do tell them we don't necessarily have a head-to-head prospective study, but Jerry and our colleague Sam Wilkinson got a very large grant from PCORI to try to answer that question. So we're actively recruiting folks into the study. It's called the Equivalence Trial, randomizing to ketamine, IV ketamine, or intranasal esketamine, and going head to head to answer that question and see perhaps which one might be better. So back to durability. If, you know, from a single infusion of ketamine, you might expect someone to have an effect for maybe up to a week. For the multi-infusion, perhaps up to a month, probably a little bit less. But the big picture here is that maintenance treatments are often needed. We rarely treat someone with a single infusion and stop. We rarely do the acute series and stop. We oftentimes need to continue treatments to maintain that antidepressant effect. So there's a lot of focus in the field on figuring out ways to extend that antidepressant effect without necessarily giving people more ketamine. So there's a lot of different perspectives that are actively being researched, combining ketamine with TMS, combining ketamine with an at-home neuromodulation device, several different pharmacological strategies, drugs that target mTOR, drugs that target AMPA, other drugs that target the NMDA receptor. I think most of us are probably aware of the dextromethorphan bupropion combination that some market as ketamine in a pill as another approach to try to extend the effect of ketamine without doing more ketamine. Several folks have combined ketamine with psychotherapeutic approaches like CBT. Our colleague Sam Wilkinson has published on that. And Rebecca Price published a really interesting paper using an app whereby participants, you know, practiced positive affirmations and an attempt to, you know, extend the antidepressant effect. And psychosocial approaches, I think, often are not spoken of enough. You know, whenever I'm seeing patients in the clinic, I tell them, when you start to feel better, right, please join a group, you know, join a community, start exercising, dieting, maybe get back into a hobby or start a new hobby, because we want you to do some things that will provide fulfillment, provide meaning for you, and extend the antidepressant effect of these treatments. Another perspective on this is the risk of continued ketamine treatment. So this was a paper that came out in AJP. The first author was one of the PGY3s in our psychiatry program. And they found that with increasing clinical use or increasing dose of ketamine, you increase the likelihood of neurotoxicity. And admittedly, a lot of these data are in non-human populations. I think the best data we have might be in the long-term esketamine studies, but most of the human data on toxicity or negative outcomes from chronic use is in recreational users. And the authors posit that perhaps we should implement routine cognitive assessments as the best observable way to mark if neurotoxicity is happening. And I think an important perspective is they also note there's no regulatory mandate. IV ketamine is not regulated by any oversight or any regulatory body, and there's no mandate to do any of these things. So we need to be judicious and careful and not do any harm, rather than just giving people as much ketamine as they would like to pay for. This is a paper that also came out a couple months ago. The first author was Christina Kumpf. She was a postgrad in the Yale Depression Research Program, now is at Virginia Commonwealth. This was a sub-analysis of ELECT-D, which was a ECT versus ketamine trial, a very large trial. And at least at this time point here, this was after the acute series, so 3 weeks of twice weekly ketamine. It seems that the cognitive batteries that were tested did not have any negative impact, and some of them actually improved over that time. But again, this is out at 3 weeks. I think elsewhere in this paper, they have observations at 30 days post-treatment, but there are no long-term studies of ketamine in this way, similar to what we see for esketamine. Now, this is from the long-term follow-up data that is published by the folks over at Janssen. This is folks that have been using esketamine weekly, every other week, up to once a month for 5+ years. These first two columns here are from the phase 3 trials that were submitted to the FDA. The endpoint is at 1 month. And we see that most of these cognitive batteries are over here on the right side, which is a positive difference. Some are here on the left, but overall, 5+ years out, a lot of these cognitive issues are not present. And in fact, a lot of people had positive impacts on their cognition with continued esketamine. But again, we don't have data like this for ketamine. This is hundreds of patients over years, and we don't have that data for ketamine. This is something that's quite important to me, and should be quite important to the field, that clinical trials of racemic ketamine are overwhelmingly white, meaning that there are underrepresented amounts of racially and ethnically minoritized groups in these trials. And the importance there is not because racially and ethnically minoritized folks have different brains or different biological features than white folks, but because they experience unique social and cultural factors that might influence or promote unique mental health challenges. So we're really missing out on perhaps finding solutions or treatments for unique mental health challenges that these groups face by leaving them as underrepresented in these trials and failing to include a representative amount. And that was in research. These are data that was published 2 months ago from large claims database, hundreds of thousands of folks, that found that white folks were offered ketamine when seen for depression at rates higher than for Asian folks, Hispanic folks, or Black folks. So ketamine-assisted psychotherapy, I'm sure a lot of you guys have heard about this, kind of different from the biological approaches that a lot of folks take with ketamine. Nevertheless, there are 2 large kind of domains of CAP. One is a psycholytic approach, where you give someone a low dose of drug, and you do some active psychotherapeutic work while their mind is a little bit loosened up. And then psychedelic approaches, whereby you give someone a macro dose, maybe 100 to 200 milligrams IM or IV. They have a very strong subjective experience, and that session is kind of sandwiched between several pre-treatment preparation sessions and post-treatment integration sessions. And the data for CAP are not many, and they're not of super high quality. But I think the best data that I've read comes from this guy Kropitsky, who's a Russian guy who was looking at what he called ketamine psychedelic psychotherapy to treat problematic alcohol use and to promote abstinence for folks that were misusing alcohol. And this is a great review of several of those studies. It might be worth looking into. Now, we all know that ketamine is a drug of misuse. It is a recreational drug for a lot of folks. It's a scheduled drug federally. But something that I don't necessarily see in the data are misuse within people using ketamine clinically. There's a lot of data around recreational users, but again, there's not that much. And part of that is because there's no central registry. to monitor these things, right? But from the available evidence that we have, it seems that people like doing ketamine, but they don't necessarily have a desire to do more. And these two papers here are consensus papers from several anesthesia groups, in talking about the treatment of acute and chronic pain with ketamine. And they don't really mention much about the concern for abuse here. And like I said, ketamine has been used in the treatment of substance use disorders for a long time. And this review here by Kelson and colleagues really sums up all of that. And it's one to really look at if you're interested in ketamine's effects in substance use disorders. Something that we can say is that the non-clinical use of ketamine is increasing, right? You can look over time, the number of seizures has been going up and the weight of those seizures has gone up. And so we can use this kind of as a proxy to say that, the non-clinical use of ketamine is becoming more popular. And the question is, why is that? Because the clinical use of ketamine is increasing and people are interested in it and want to get it. But we're unsure, right? We can't really make a conclusion, but these are the data, and this is a trend that's actually happening. So that leaves us here, where, this headline is kind of sensational, calling this a Wild West, but, there are no regulations on using IV ketamine in psychiatry. If your patient consents and you're a licensed provider, you can do this. There are several anesthesiologists, family doctors, neurologists, emergency docs doing ketamine treatments for mental health disorders. I'm not knocking them, but what I am saying is that we do need to have a regulation to make sure people are doing these things in the appropriate way. And that's something that was thought about really hard, really thoughtfully when esketamine was up for FDA consideration for approval. The development of the Spravato REMS has been really essential in providing monitoring and safety monitoring for folks. And the patient has to register, the clinic has to register. There's a monitoring form that goes in with every treatment, and adverse events are supposed to be reported to the REMS so they can monitor and track those. This is a report from a toxicology journal showing that ketamine misuse has been increasing over time, whereby esketamine misuse seems to be remaining relatively flat. And again, we can't draw any concrete conclusions from this, but I'd be willing to bet that it's because of the REMS. We are mandated to do esketamine in the clinic. Patients cannot take it home. And this really kind of prevents diversion and promotes the safe use of ketamine in clinical, or esketamine in clinical contexts. So this paper is a landmark paper that we participated in here at IPS. This is a very large prospective study. The N was 365. The ketamine group, I believe, was 195. I think it's the largest prospective study of ketamine that's been done thus far. And we found that ketamine outperformed ECT. It was significant for the non-inferiority. It was significant as non-inferior to ECT. And this paper kind of ruffled a lot of feathers. And there are some design flaws that I'll just point out that people like to point out, that we compared IV ketamine with ultra brief right unilateral ECT. Oftentimes people think of bilateral ECT as more efficacious. Oftentimes, if someone's not responding, we here at Yale go at treatment 6, we might switch over to bilateral. That wasn't done in this trial. And most of these patients were outpatients. ECT is thought of to be more effective for inpatients and for those with psychotic depression, and those folks were not included in the study. And if you look at the number of folks that withdrew from the study after randomization, there was about 7 times as many people that withdrew after they found out they were getting ECT, which again might point towards expectancies, right? Perhaps the people that stayed in the study and got ketamine expected to get better at higher rates, and that might influence the outcomes. But nevertheless, this was a huge study, multi-site study at several academic institutions that have been doing ketamine and ECT for a long time. Amit Anand, the first author on the study, was also on that original Ron Berman study, that first ketamine study. So, I mean, these are not amateurs that were doing this, and I think these data are pretty strong. This is a analysis that was done, though, by Greg Ree, who was the statistician at the Yale Depression Research Program. has written a lot about ketamine and ECT. And when you look at the pooled analysis of studies that compared ECT and ketamine, it seems that ECT is favored. But I think something of note is that the sum of all of these trials is still less than the sum of the ELECT-D study. So take it with a grain of salt, whether or not the pooled analysis you want to have more faith in, or in the single high quality prospective study. These are the data. I won't lean either way. I'll let you make your own decisions. This is another paper that, in my mind, was landmark. This was 676 patients where they compared esketamine versus the addition of quetiapine, both of these as an adjunct to an SSRI or SNRI. For those of us that treat depression, augmentation with a second-generation antipsychotic such as aripiprazole, quetiapine, or risperidone is very common. Some people think of it as second line, third line. So comparing esketamine to quetiapine will really answers a nice clinical question in terms of algorithmically, what should we do next if people are failing? So at least in this trial, esketamine outperformed quetiapine with a remission rate of about 27%, which again aligns with those larger analyses that showed around 30% remission with intravenous ketamine and esketamine. This is a paper that came out from Janssen. I mean, this paper really supported the petition for monotherapy for esketamine. Both of these two doses outperformed placebo. This was a large study, 378 folks, 51 different sites in the US. Both of these doses outperformed placebo. If you take a look, both of the doses had MADRS scores change from 13 to 14 points, which is pretty good. I will say that in the large phase 3 trials that Janssen submitted to the FDA to get approval initially, those trials were in combination with an antidepressant and compared to someone starting a new antidepressant. And I believe the changes in MADRS scores in those studies were larger than these, right? So even though monotherapy outperformed placebo, I wouldn't say it necessarily would outperform the combination of esketamine and an antidepressant, and I don't think this changes my clinical practice much at all. But nevertheless, it was given approval as a monotherapy, and the first and only monotherapy for TRD. This paper is getting a lot of traction. At least a lot of people have texted me and said, "Hey, ketamine doesn't work." Right? This was 65 folks that were hospitalized on an inpatient unit, and they compared ketamine to midazolam and treatment as usual, and they found no separation at their endpoint. They did find a between group difference of about three points, and in large clinical trials of antidepressants, a between group difference of 2 to 4 is generally statistically significant, and a little bit higher might be clinically meaningful. And when people ask me what I think about this, I think the study was a bit underpowered with the 65 folks. It's possible that with a population maybe 3 times the size, we might have seen a separation here or not, but we'll never know, right? So, I think this was a valiant effort and adds to the literature around ketamine, but I wouldn't put all my eggs in this basket because I don't think the study was powered well enough. And this study is showing extended release ketamine tablets. And like I mentioned earlier, the oral versions generally have very low bioavailability, but this is just another exploration of another route to give ketamine. This was an enriched study, so people were given 120 milligrams daily. The responders then entered the randomized controlled portion of the study, where you got either one of 2 low doses, one of 2 high doses, or placebo. And they found that the highest dose, 180 milligrams, prevented relapse at the highest rates, right? With a difference in MADRS scores at the endpoint of 6, which is pretty good. So they're actually looking at this 180 milligram dose in phase 3 trials. I'm really looking forward to the reports from that, those data. And it's important because that trial, they gave people the oral tablets in the clinic, right? And these are screenshots from my Instagram. I am a millennial. I do use social media. And these are screenshots that I get, targeted ads talking about ketamine, telling me that it feels like magic, right? True quality K is hard to find. We deliver. Kick your antidepressant and depression and antidepressant pharmaceutical meds to the curb, which is implying that you might not need to take medications anymore. And I think advertisements like this are wildly inappropriate. And again, without regulation on some of these things, this is what we're looking at. This is where we're headed as a field. So, there are companies sending people ketamine to inject at home. And Wall Street Journal even covered this shortly after Matthew Perry died, talking about these companies and how we're moving into this phase where people are doing ketamine at home. So the FDA picked up on this a couple years ago and released this warning, or they warn people about compounded ketamine products. They state very clearly that ketamine is not FDA approved for the treatment of any psychiatric disorder, right? And that compounded drugs have not been tested in clinical trials, and the safety data is not there. So you can participate in this if you want, but again, if we're talking about do no harm and do what's best for our patients, this might not be the way to go. And several of our colleagues, including Jerry and Sam and our colleague Lisa Harding, have published on just that, advocating for the increased regulation, monitoring, and perhaps a registry for folks that are administering or using ketamine clinically. And lastly, I wanted to mention this because it is a hot topic. Someone just asked me about this. There is a company that is investigating and developing a preservative-free racemic ketamine. They recently got FDA fast track designation, and if at some point they get approved, I'm sure there'll be some type of increase in regulation, hopefully the development of a REMS for this. But interestingly, they also recently asked the FDA to ban all products containing ketamine that had this preservative in it. So this was, 2 months ago. I'm not sure where that's going to go, but if that were to go through, right, the supply of ketamine would drop drastically, and it would have far-reaching implications. So I'm really keeping an eye on this. And lastly, I wanted to mention our colleague Sophie Holmes. We just wrapped up this really interesting study using ketamine for depression and Parkinson's disease. I believe we're unblinding this week or next week. The data should be analyzed, and hopefully a report will come out sometime next year. But this was a really interesting study, and look out for the results sometime soon. Okay. So Jerry, you want to take it away?
Great. Thanks, Marcus. Great job. I think you did a really great job of giving the overview, especially as it pertains to IV ketamine. What I just wanted to do is just add a little bit of context, especially what we have done more recently, because there have been a few papers that have come out that really covers a lot of the holes that we had in the field. And I'll just start by saying, going back, this was 10 years ago with one of my colleagues, Alan Chatsberg. We wrote this paper, and this is early in the stages when ketamine was being developed. And really, this was a point counterpoint. Is this really a useful new treatment, or is just a dead end thing that's leading the field down the wrong direction? And you may be able to guess who was on which side of that debate during that. But Marcus, if you can go to the next one.
Mm-hmm.
But it was shortly after that the APA actually came to me and a few of my colleagues. They asked us for the Council of Research and the Task Force on Biomarkers and Novel Treatments if we could write some guidelines. And I think Marcus referenced this. And pretty quickly, we started to look at the data and said, how could there really isn't data to write guidelines. To write guidelines, you need data to build it on. And this was back in 2016. There just wasn't. There were a bunch of these small N studies, Ns of 20, Ns of 30, done under different protocols. So there really wasn't data, especially on the long-term efficacy or safety of the drugs. We really were stuck. We couldn't do much to move beyond that. So the future directions that we asked for was larger standardized clinical trials and some coordinated system of data collection so we could learn what is actually happening. Marcus, you want to, so that's perfect. The next one is good. And as most of you all know, Janssen, a subsidiary of Johnson & Johnson, actually picked up esketamine, which Marcus explained to you is really just the S enantiomer. And they ran a large portfolio of phase 2 and phase 3 trials. Now you can see the ends are very different. And this is with intranasal esketamine. And now you're seeing hundreds of people in the study, and you're seeing studies that are running over at least to a year. And this is the package that was required for the FDA approval. And with this package, they were able to get FDA approval. And Marcus, next slide. And they got FDA approval, as you already heard, in 2019. But with that came the REMS, and Marcus discussed the REMS, and the REMS had several components to it. The one component was dictating how it was used. It had to be a registered pharmacy. It had to be a registered health service that was doing it, and individual providers had to be registered. You had to have a register of every patient, and every single time, any of you that's given Spravato, intranasal esketamine, you have to fill out a REMS form every single time you treat them. So that was part of it. We're going to come back to that. The other thing that the FDA asked for was from long-term post-marketing data. And what we actually did there was the study that followed people out for 1 year. We allowed other people into that, and then we followed people for up to 5 years. So this is some of the data that came out earlier this year looking at that. And now you're looking at data over 5 years for people, or over 4 years, going on 5 years for people. And you can see this is a small graph to your left. I don't know if you're able to see it, but what we really see here is the frequency of treatment, with the blue being weekly, and as it's typically prescribed, is once you move from the twice a week for the first month, you move into weekly. But then over time, the idea is that you can go to once every 2 weeks or even once a month in this study. And you can see the relative ratios. The blue are people that just continued to get it once a week. The red was people that went to once every 2 weeks. And then the green is people that were spread to once a month. But it gives you a real idea, at least in this group that was followed very closely, how frequently people were getting treated. On the right, I think, is very encouraging information. This is looking at large sample, and you can see the sample size down there. So you're looking at hundreds of people being followed, going out over 250 weeks, so long period of time. And you can see that in general, when people did get better, they stayed well. I mean, if you're looking at the error bars there, that's because you have so many people. Not everybody. Individual patients are bouncing around, and not everybody got well and stayed well. But overall, it looks like the treatment can maintain its response. But in general, people are getting treated once a week or once every other week for the most part. The majority of people at least are. All right, next. And this is really another way of looking at the effectiveness of the treatment. So again, I wish the colors were a little greater contrast, but you can actually see this is looking at how severe people were at baseline coming into this long-term study. And you can see that really dark green is very severe extreme depression. The other more sort of classical green, and that really gets minimized as time goes by within the first month. And then in this graph to the right, which is really small, you can see the number of people in the more severe group really maintains at a very low level, and that the large majority of people are either in the normal or borderline or moderate. So people from the more severe levels got better. At least they dropped into the moderate or borderline and stayed there, the people that stayed in it. So this is really encouraging long-term data, looking out over years, the people that are followed very closely. This is not a real world sample. This is very close follow-up in an open label clinical trial, but very closely followed. Next slide. And then we also have really good idea of what side effects you can expect. And this is anything looking over 10%. And you can all read this paper. It's, it was published earlier this year. I'm not going to go through each one of these things. I wouldn't expect anybody to, but the main point is it's there. You can look, you can really know what type of side effects you should be expecting. All right, next. So this is getting back to the other side. So I remember the FDA asked for two things. They asked for long-term control trial, looking at that, not randomized control, but a long-term trial, and that was given. But they also asked for the REMS to include a registry. And that registry, every single patient that's been treated is followed. And then, it's called the risk evaluation mitigation strategy. That's what a REMS is. So we were able to use that data. I was able to go to Janssen and say, listen, we've been collecting data for 5 years, filling out these forms. And anybody who has to do this, it's kind of painful filling out these forms every single time for every patient. Let's actually look at that data. Now that we have all that, let's go back and see what is it actually telling us. So that's what this paper is. This came out earlier this month or at the beginning of last month. This is the data looking at almost 5 years, just about 5 years worth of data from all the REMS that were completed. And you can see, and it ended going back in January 2024. That's how long it takes to get these papers finished and published. But so it's the data all the way up to that point. And the amazing thing you can see is how many people this actually is. So it's covering 58 months of treatment, but there's over 58,000 people that have been treated, and just about 1.5 million doses given. So now we have a really good idea. So going back just 10 years ago, and I was saying, well, we don't really have any data, long-term efficacy or safety data. Now I think it's fair to say we have better long-term efficacy and safety data than we do for Prozac. Now we have really intense long-term efficacy and safety data, at least for intranasal esketamine given under the REMS protocol. So if you can go to the next slide. And some of the stuff you can see, first you can see the demographics. So it's over 58,000 people treated, nearly 1.5 million sessions. The majority were female, just as you would expect. And the large bulk of these people were between the ages of 18 and 75, with most actually being between 26 and 55. Interestingly, the uptake really seems to be greatest in the South and the Midwest. The lowest rates were actually in the Northeast and in the West in California, actually, or the West Coast. So it's interesting. Just also quickly on the right, there's so much data here. I don't think you're going to get it all, but you can just read this paper. It's in the American Journal of Psych, the last issue of it. But you can see the rates, the use of ketamine. These are the bar graph going up quite a bit each year and continuing to go up. So it was a little slow with its initial uptake, but now it's really increasing. We can talk about that more. And then you can look at the rates that the 84 or 56 milligrams, this is right below it, and see, you can see that people start using the 56 but quickly decrease when the use of 84 milligrams increases very rapidly. This is just the total number of people receiving so many sessions. And then the figure D is really just showing that the only people that really receiving any lower doses are the elderly patients. So it is interesting because if you look at most studies that were done, either the phase 3 studies, the fixed dose between 56 or 84, or even the monotherapy, there's very little difference between 56 or 84 efficacy, but yet everybody goes right up to 84 so quickly, when there's really not great data to support that. But I think we're pretty simplistic in medicine. We always think more is better, and that might not be the case here, but it's something we always jump to. All right, next slide. So here's the safety data from that, the REMS, and there are two ways that the data were collected. One is the REMS, those forms that you fill out each time. So this is looking at the safety data from that. And there was 3 specific adverse events of interest: sedation, dissociation, and increased blood pressure. And you can actually see now we have with really high levels of confidence how much you can expect to see this. So, the majority of people are going to have sedation and dissociation. That's no surprise to anybody. This is all during those 2 hours. But increased blood pressure, meaning an increased blood pressure going up above 180 systolic, or going up above 105 diastolic, which is a meaningful increase in blood pressure, you're going to get about 10% of people, about over actually 11, almost 12% of people getting that at some point if you're going to treat them long enough. But if you actually look at the chances of that happening on any individual session, it's less than 1 in 100 per session, but you're going to get that. That is going to happen if you're treating patients with ketamine. You're going to get that increase in blood pressure. And then if you look at the actual chance of a serious adverse event happening, you can see with patients, it's almost about 2%. But if you're looking at actual individuals, things about 1 in 1,000 chances of getting an adverse event during a treatment session. Basically, that's what was picked up on the REMS. If you go to the next slide. This is just looking at the serious adverse events that were picked up by the REMS. And there's a few learning points that I want to make from this. The one is if you looked at the most common serious adverse event, which accounted for 7.5% of all the serious adverse events reported on the REMS, even if you look at the first one, the third one, fourth one, those 4 account for a big chunk of all the serious adverse events. I mean, if I was in a group here, I'd ask you guys, how many people here know the definition of a serious adverse event? Because there's a very specific definition. And I think a lot of clinicians, understandably, this is not what they do. They can confuse a serious adverse event with a serious adverse event with a severe adverse event. They're not the same. Serious adverse events basically mean that somebody either died, they had to go to the hospital, had an extended hospital stay, it caused some congenital birth defect, it caused a life-threatening event that if intervention wasn't taken, somebody could have died from. So those are really the definition of a serious adverse event. I don't think vomiting, nausea, or dizziness meets that criteria. But that in the REMS, that is getting coded as a serious adverse event. So it's just something to understand. When you use real world data, you have to be careful, what you're actually extracting from it. We can go to the next slide. Now this is actually looking at the serious adverse events using the classic definition of the good clinical practice guidelines. And now you can see that the number of serious adverse events by patients and by treatment sessions are pretty rare for these type of events to ever happen. Now again, you talk about using real world data. This is the other big learning point from this. So this was all extracted from the REMS. This is all the time that you fill out those forms when somebody comes in and you fill it out. But when people don't come in, you don't fill out the form. So if adverse events happen after the last time you filled out the form, you would not necessarily pick it up. And this is my big concern when people are using real world data and saying, well, people did really well. Some of these take-at-home ketamine studies say, well, we had very few side effects, but then they lose more than 50% of the people. In my mind, they all died. If you didn't follow up, the person died, because you couldn't prove they didn't die. So to say that that's safety, that's not necessarily good. And I think here's an important thing. So beyond just using the REMS, we were able to use, if you go to the next slide, the global medical safety data, and this is specifically for the US. So this was a second way of addressing this that Janssen had. So they were getting data from social media, they're getting data from all different sources. And now you can see, if you look at number of deaths, there are about 109 deaths. Only 2 of them were picked up in the REMS, though. So you see, the importance of, because any of you who do this, that the REMS, if you don't fill out a REMS after a period of time, somebody starts hounding you, start asking you, where's your discharge for this person? You have to discharge, and then you have to say what happened to them. So this is a way of really ensuring that you get data on on people after. You don't just drop them out of the study. So now you can see that there were a different group. And now you can see that there were, like, this is accounting for all the serious adverse events. There was suicidal ideation picked up, more hospitalizations, and you see there are actually 109 deaths that was included in here, and completed suicides were 70. Now, this is really important data to have. I mean, remember, this is treating almost 59,000 people. If you look at the relative ratios, that's about what you would expect, actually a little bit lower. But it's really hard when you do this real world data to get what's called propensity matching. So if you want to compare a specific group to the population, you have to decide who the appropriate population is. So do you compare this to all people in the population, or do you compare this to people with depression? Do you compare it to people with treatment-resistant depression? It gets very complicated how to do that. But I think the take home from this is, the number is well within the level that you'd expect for people with treatment-resistant depression, probably even at the lower end of that. So I don't think we're seeing a red flag at all here. And then if we can just go to the next slide. All right, and that's really what this covers. And I would advise, read this. The paper is actually really good, and it's a really good reference for you to know what you should be expecting. So you can go to the next slide. All right, it's great because I did want to leave time for comments and questions. Hopefully a little time is left.
Yeah.
Thanks.
Thank you. Thank you so much. This was so engaging. And of course, it is time for questions, comments. Everyone feel free to either raise your hand. We can unmute you and turn on your camera, or you can put a question in the chat. There we go. We have one. Give me 1 second. Robert McClure. I've enabled your camera and mic. You can speak.
Great. So thank you so much for the presentation. The question I had was, has there been efficacy, long-term and short-term, as well as safety data comparing administration of racemic ketamines subcutaneously to other methods of delivery?
So, Jerry, do you know? I've read some data on sub-Q administration of ketamine, but I'm not too well versed in it. I'm not sure if there's a large body of literature there. Are you familiar with this, Jerry? Or?
So I can say there is not a large body of literature associated with it. That's the problem. And some of the reports that are there, aren't doing the intense active follow-up that we typically would like to see. So in terms of high quality data, I'd say it just doesn't exist. And that's one of the problems. We either need a really large clinical trial, which would cost literally tens of millions of dollars, or we need some way of having a registry to collect real world data that's believable. So I'd leave it at that for now.
That's very helpful. Thank you.
Thanks, Robert.
I wanted to ask about,
Yeah.
sorry.
Go
for the
ahead,
comments,
go
Coach.
ahead,
I was just curious about the use of midazolam as kind of a better comparator than saline, because the data is very poor, but there's some data to suggest that benzos may accelerate antidepressant response or what have you. So I'm curious, you guys think if that's a really a better control than saline or not?
Yeah, I mean, I like I mentioned, I think it's important to try to do something where people can feel something. I know some people might use diphenhydramine as well. I think in some of the trials of psychedelics, people might use niacin. I think in the study you were on, Jerry, I think that's what they used. So I think the point is to try to give someone a feeling that something is happening. But whether or not midazolam is the optimal comparator, I'm not too sure. So do you have any thoughts about that, Jerry? Or?
Oh, I mean, I think it's what's the best for what question are you trying to answer? If you're really concerned is this some functional unblinding impacting, then yeah, midazolam is definitely, and I think the Wilkinson paper shows better than saline in doing a job at blocking that functional unblinding, or what I actually call sort of an inverse placebo effect. Because if you know you didn't get the drug, you don't get a response. And that's what we see a lot in the psychedelics, where there's like no placebo response. And once I see no placebo response, then I just know, all right, well, this is functional unblinding, because you just expect placebo to be about 80% of the total response. And if you don't see that, then it doesn't say much about a drug. It says a lot more about the placebo. So I think that's it. But to say it's better, when we were originally doing these studies back in the early 2000s, there was evidence, ketamine was probably actually safer than giving IV midazolam. So, you run into these unique things where the placebo could actually be more dangerous than the treatment you're giving. And that's not really how it's intended. And does the placebo, is called an active placebo, does the placebo actually have some antidepressant properties on its own? And that's, I think, what you're getting at. So I think it really depends on what question you want to answer. They each have their own role.
Amazing. Thank you. I do see one hand raised. Thomas, I'm gonna enable your camera and mic.
We can't hear you, Thomas.
We can't hear you.
Now I can unmute my mic. Yeah. I was just curious, and this may be a misunderstanding on my end on how it works exactly, but I was curious on your take. Like, at some point when thinking about these studies, I've been thinking what it would be like to repeatedly come into ketamine sessions and sit there and have absolutely nothing happening with like a 3-ish hour monitoring period every single time. I'm wondering like whether that in and by itself can have a nocebo effect when you're essentially just sit around. So my question is like, how do people normally keep participants entertained during that time? And do you think this is an issue, or is this just something that comes out of my mind?
So, I mean, in general, I think, at least I can only speak for, what we do here. But generally, we encourage people to do whatever it might be that they think would be helpful to pass that time. I mean, we keep them generally for around 2 hours for the IV transfusions, maybe a little bit less. But commonly people, listen to music or bring a book or eye shades. A lot of people actually go to sleep, interestingly. So, we often encourage people to do whatever it is that they think might be fitting to pass the time. Yeah.
Yeah, Thomas, I'll just add to that a little bit. I mean, I think if what you're getting at is the bigger question, which I think set and setting are incredibly important in all of medicine, not unique, that's talked about a lot in psychedelic treatments, but I think it's, maybe almost equally important across all of medicine. Set meaning the mindset that somebody comes in, their expectations, their beliefs, their hopes, and setting being the actual place that you're treating and how much that matches with your set. I think that's incredibly important. I don't think we know that much. I think understanding the matching of those two are really important, that the setting is matching the expectations is probably really important. If somebody walks in and they think I'm going to have this blissful experience and I'm going to have, certain setting and it doesn't match that, that could actually have a nocebo-like response. But if you come in thinking you're going to be treated in a medical setting and you're going to have EKG monitors and everything, and you walk in and there's a room with flowers and everything else, you may say, oh, that's not really going to work. So I think, I don't think there's a simple answer, and I think it's probably a lot of contextual factors based on individual beliefs that are really important. And I think I'm not in any way trying to minimize it, because I think those effects are huge, but I don't think they're simple.
Yeah,
Thank
and
you.
I think that it's important, at least when you're seeing folks clinically, to kind of check all those boxes beforehand. So when I'm talking to people, I ask them and I tell them this is the setup that we have. Some people come in and they expect, a spa-like environment with private rooms and a shower and a massage at the end, whatever it is. But, you have to be upfront with people to manage their expectations so you don't end up creating a negative situation for them, which might negatively impact the outcomes of treatment. So.
Thank you. Thank you, Dr. Sanacora and Hughes, for such an
Thanks.
engaging session. And thank you all for joining. We'll see you next month at the happy hour and then in the new year. Happy holidays.
All right. Thank you all.
Bye.
Thanks.